The next item is a presentation by CNSC staff on the study of consequences of hypothetical severe nuclear accident. Before moving on the presentation, I'd like to acknowledge the participation of a representative from OPG. There are other department or ministries that are also present here. I understand from Health Canada and from the Office of the Fire Marshal and Emergency Management. And we have some guests online. So let me start with Ms. Branch from Washington, I understand representing the Battelle Seattle Research Center. Ms. Branch, can you hear us?
Yes, I'm here. Thank you.
Thank you. And I understand that we have people from Office of the Office of Fire Marshal. So can you identify who is online?
Is on the line.
Okay, thank you. And I understand we have some people from Health Canada. I can see Health Canada people. Good, thank you. So, Dr. Thompson, I understand you're going to make a presentation as outlined CMD 14 M30 and M30.A. The floor is yours.
Alors, bonjour Monsieur le Président, Mesdames et Messieurs les commissaires. Mon nom est Patty Thompson. Je suis la directrice générale de la Direction de l'évaluation et de la protection environnementale et radiologique. With me today are Mr. Andrew McAllister, the Acting Director of the Environmental Risk Assessment Division, and Ms. Melanie Rickard, the Acting Director of the Radiation and Health Sciences Division. They will be making today's presentation. We are supported by a team of CNSC staff with expertise in reactor safety and regulation, emergency management, and health risk assessment. Dr. Lydia Zablatska is an associate professor of epidemiology at the University of California, San Francisco, and she has an MD and a PhD in epidemiology. Dr. Zablatska was the peer reviewer for the Human Health Risk Assessment section of the report, and she is available and present here today to answer questions. Ms. Christy Branch, who you know is on the phone from the Pacific Northwest National Laboratory, provided the expertise on the psychosocial effects section of the report. Ms. Branch is also available to answer questions. Staff from representatives from Ontario Power Generation are also present and available to answer questions. They were responsible for the part of the study that dealt with the release to the environment, the dispersion modeling, as well as the dose calculations. Before turning the presentation to my colleagues, I will provide a little bit of context. This study is being done in response to direction from the Commission from the March 2013 Record of Proceeding on the environmental assessment for the refurbishment and continued operation of the Darlington Nuclear Generating Station. With support from the organizations and individuals that I mentioned a few minutes ago, staff conducted the study of consequences of a hypothetical severe nuclear accident and effectiveness of mitigation measures, and the report, as you know, is attached to CMD 14M30. Today's presentation will provide an overview of this study and some highlights from the findings. I will now ask Mr. Andrew McAllister to continue with the presentation.
Thank you, Dr. Thompson. For the record, my name is Andrew McAllister, and I'm the Acting Director of the Environmental Risk Assessment Division. I will begin by providing a brief outline of our presentation. As you can see, it includes information around the reason for the study and its approach, and some background information to establish the context for today's meeting. This information is followed by a discussion of the study results and insights, and the relation and applicability of this study to other nuclear power plant sites. The presentation will conclude with CNSC staff's proposed next steps. The following slides will cover the reason for the study, the overall study approach, as well as some information on risk assessment and risk acceptability. In December 2012, during the course of the hearings on the environmental assessment for the refurbishment and continued operation of the Darlington Nuclear Generating Station, interveners raised concerns over issues such as the severity of the accident assessed, multi-unit accidents, adequacy of off-site emergency planning, including evacuation planning, and potential health effects to the public. During the hearings, CNSC staff confirmed that the beyond design basis accident associated with an off-site release that was assessed for human health and environmental consequences was credible and sufficient for the environmental assessment. However, staff did indicate that a more detailed examination of a severe accident was possible. Subsequently, in its March 2013 record of proceedings on the environmental assessment, the Commission directed staff to assess health and environmental consequences of severe accident scenarios and to update the Commission accordingly. The update to the Commission was to be in the form of an information document or equivalent. This slide presents the high-level steps of the study that were undertaken to address the Commission's request. Staff of the CNSC and Ontario Power Generation worked together to carry out the study. Ontario Power Generation, or OPG for short, carried out the work with regards to the identification and modeling of the release, including the dispersion modeling and dose assessment. The results of this work, specifically the dose assessment, was provided to CNSC staff, who then completed a human health risk assessment with due consideration to protective actions and an examination of other consequences. Some of the other consequences examined included implications to emergency planning, psychosocial effects, and effects to non-human biota. When we use the term non-human biota, we are referring to wildlife. In the coming slides, we will clarify what is meant by the term generic large release, and will speak to the concept of protective actions in more detail. To situate the work that was done in this study, we will explain the concept of risk assessment. A risk assessment is intended to provide complete information so that the best possible decisions to protect people's health can be made and the highest quality information can be communicated to the public. Typical risk assessments are made up of 4 steps. The first is problem identification, where information is gathered on the contaminants and baseline conditions are determined. In this study, the contaminants are radioactive material. The second is to perform a dose assessment, either through modeling, direct measurement, or a combination of both. The third is to evaluate the dose response from scientific literature to identify what effects are associated with the radiological contaminants and how those effects can vary with dose. Lastly, all this information will help characterize the risk by establishing the probability of an adverse outcome occurring to allow for judgments to be made about whether or not these risks are acceptable. As you can see, the steps are presented in a loop, and as over time, it may be necessary to revisit the risk assessment. As we described to you today how the study was carried out and its results, we will demonstrate how this approach was used. With respect to risk acceptability, national and international organizations such as Health Canada, the World Health Organization, and the International Chemical Safety Program consider that an incremental lifetime cancer risk for chemical and radiological carcinogens of 1 in 100,000 to be essentially negligible. This risk benchmark is used along with other factors to determine the need to consider management options to reduce the risk. Examples are contaminated site remediation programs in countries such as Canada, Australia, and the United States, and chemicals being used or produced through industrial processes such as priority substance assessments in Canada under the Canadian Environmental Protection Act, as well as internationally under the Organization for Economic Cooperation and Development, the World Health Organization, and the International Chemical Safety Program. For this study, in alignment with international guidance, CNSC staff used the 1 in 100,000 to 1 in 10,000 risk band to put findings of the health risk assessment in context and to identify situations where additional risk management actions may need to be considered. The next few slides describe some background information that relates to the study. It is important to highlight that the study is theoretical in nature and does not reflect the state of enhanced readiness of Canadian nuclear power plants, the operators, or responsible authorities to be able to address a severe accident. Inherent in the robust safety case is the defense in-depth approach. This is a comprehensive approach to safety to ensure with reasonable confidence that the public and the environment are protected from any hazards posed by a nuclear power plant. The concept of defense in depth is applied to all organizational, behavioral, and design-related safety and security activities to ensure that they are subject to overlapping provisions. With the defense in depth approach, if a failure were to occur, it will be detected and compensation made, or it would be corrected. This concept is applied throughout the design and operation of a nuclear power plant to provide a series of levels of defense aimed at preventing accidents and ensuring appropriate protection in the event that prevention fails. With that in mind, Canadian nuclear power plants are fundamentally designed and operated to withstand or minimize releases, namely controlling the reactor power, cooling the fuel, and containing radiation. The events that are listed in this slide reflect progressively worse events. However, for each of these, there are multiple means to arrest the progression of these events, meaning to stop them, and means to minimize the releases should they occur. With respect to CNSC's response to the Fukushima accident, the CNSC task force confirmed that Canadian nuclear power plants are robust and have multiple layers of defense. The Canadian nuclear power industry is on track to complete all Fukushima action items identified in the CNSC Integrated Action Plan by December 2015. Aspects such as emergency mitigating equipment, both on-site and off-site, severe accident management guidelines, or SAMGs as they are often referred to, as well as plant design features such as containment filtered venting systems will further strengthen the safety at nuclear power plants. The safety improvements being implemented at all Canadian nuclear sites as a result of Fukushima lessons learned through enhanced design and operating procedures will further increase safety margins, thereby practically eliminating the likelihood of a severe accident with serious radiological consequences. The source term serves as the basis for the generic large release that was mentioned a few slides ago. Source term is a word used to describe the radionuclides and their quantity that are released into the environment. As directed by the Commission, the source term considered in this study is greater than the source term previously assessed in the Darlington Refurbishment Environmental Assessment. It is greater by 4 to 5 orders of magnitude. Further, the record of decision directed staff to look at the accident scenarios discussed in the course of the hearings. The source term used is comparable to a severe accident scenario described in the Darlington Probabilistic Risk Assessment that interveners highlighted during the Darlington refurbishment hearings. It has a probability of 3.7 times 10 to the negative 7, or 3.7 in 10 million. It was referred to as a release category 2 accident. For this study, a generic source term was derived based on CNSC's large release safety goal of 1 times 10 to the 14 becquerels of cesium-137. This is the safety goal outlined in CNSC's recently published Reg Doc 2.5.2, Design of New Nuclear Power Plants. The safety goals, which are based on modern international recommendations, have been established to ensure plant design features are in place to limit the risk to society and the environment to acceptably low levels. With 1 times 10 to the 14 becquerels of cesium-137 as the source term basis, other radionuclides were added to the source term in a quantity scaled to the amount of cesium-137 considered and reflective of the radiological inventory of a Darlington reactor unit. In other words, though the accident is hypothetical in nature, the source term is derived from the actual radionuclide inventory from Darlington. To ensure the study was robust, a wide range of release scenarios reflecting a spectrum of potential emergency response requirements were considered. There are 2 key aspects to describe a scenario, namely the hold-up period and the release duration. Hold-up refers generically to the period of time between the radioactive material being released from the reactor core to then being released into the environment. It is normally held up by containment prior to its release. Release duration is the length of time that the radioactive material is being released to the environment. With respect to hold-up period or timing of the release, it was set at 24 hours, which is generally consistent with our understanding of accident progression at Darlington. To put the hold-up period into perspective, for Fukushima, the hold-up periods range from 24 to 74.5 hours. With respect to duration, 3 release durations were chosen. Short, meaning 1 hour in length, medium, meaning 24 hours in length, and long, meaning 72 hours in length. The scenarios are referred to respectively as 24-1, 24-24, and 24-72 scenarios. The generic large release was the same quantity of radionuclides released for each scenario, albeit in 1, 24, and 72 hours. To put the release durations into perspective, the 1 hour duration scenario would be comparable to a significant breach of containment, whereas the other 2 scenarios, the 24 and 72 hour durations, indicate partially or fully intact containment with venting occurring, for example. With respect to the last bullet, we heard the concerns from interveners about the absence of a Fukushima type of release. It is recognized that an accident like that at the Fukushima Daiichi nuclear power plant is unlikely to happen in Canada, reflective of the CANDU design, and these aspects are discussed further in Chapter 2 of the study document. However, to be responsive to interveners' concerns raised during the hearings, the source term was increased fourfold for the 24-24 and 24-72 scenarios to be comparable to a common cause event affecting all 4 units at Darlington. Note, this is a simplistic way of looking at a multi-unit event. The 24-1 scenario was not considered for the fourfold increase in the quantity of radionuclides released. This is because as a multi-unit event with this short release duration, it would be indicative of a sudden and complete failure of containment in all related safety systems across multiple units, and this is not considered plausible. For all scenarios, the release was in the form of a plume dispersed in the atmosphere. A key assumption was assumed releases, meaning Fukushima enhancements such as emergency mitigating equipment were not accounted for, and the source term was assumed to be released in its entirety. As discussed previously, the 24-hour holdup is supported by the understanding of the CANDU reactors of containment and the vacuum building functioning as designed. As presented to the Commission at the Pickering Hold Point hearing held in May of this year, Fukushima enhancements such as emergency mitigating equipment could result in a risk reduction of up to a factor of 10. To highlight the importance of operator actions, we can look at studies done elsewhere. A study done by the United States Nuclear Regulatory Commission examined scenarios where accidents were modeled with and without operator actions. With the operator actions successfully carrying out mitigation measures, it was predicted that the progression of the accidents examined would be halted within approximately 5 hours. In the absence of operator actions, there would eventually be releases. Another key assumption in the study are the wind conditions. There are 2 key components, namely wind speed and direction. The model that OPG used for dispersions and dose assessment is called the Melcor Accident Consequences Code System 2, or MAXIS 2 for short, and was developed for the United States Nuclear Regulatory Commission. It used meteorological information from the Darlington site that included wind speed and direction to simulate the movement, i.e. dispersion, of the radioactive plume through the landscape and to estimate the subsequent doses. The model uses a grid similar to what is depicted in this slide, and note that this grid is not to scale and is for illustrative purposes only. A diagram of the actual grid is found in Annex 2 of the study document. However, it is illustrative for the fact that there are 10 radial rings at various distances starting from the release point and moving outwards, and there are 16 different wind sectors or slices of the pie that we are seeing, and the wind is allowed to move through those sectors and radial rings to simulate the wind conditions at the site. With respect to the scenarios that we were looked at, constant wind, meaning constant speed and direction, was applied to the 24-1 scenario given its short release duration. For illustrative purposes, that is depicted by this one arrow on the slide. For the 24-24 and 24-72 scenarios, the model breaks the release duration up into 4 equal segments. So we had 4 6-hour segments for the 24-24 scenario and 4 18-hour segments for the 24-72 scenario. This allows the model to account for changes in speed and direction which are expected over time. These remaining arrows are associated with variable wind to depict how wind and speed can change over time through the landscape. So far, a few of the key assumptions regarding the source term and dispersion modeling have been discussed. The model performs a dose estimation based on the dispersion of the source term, and this leads us to a discussion of emergency preparedness and response, which we will cover in the next few slides. Regarding emergency preparedness and response, the estimated doses inform decision makers on actions that should be taken to protect the public. These protective actions will be discussed in a few moments. First, however, we will describe the overall responsibilities regarding emergency preparedness and response and discuss a few key terms. There are responsibilities across multiple jurisdictions and stakeholders. In terms of on-site response, the licensee is responsible. However, the CNSC continues to retain its regulatory oversight. For the off-site response, the province is the lead authority, with the Office of the Fire Marshal and Emergency Management being the central organization responsible for administering Ontario's Provincial Nuclear Emergency Response Plan, or PNERP for short. The Office of the Fire Marshal and Emergency Management is with us here today in the room and on the phone. In order to effectively carry out protective actions, predefined emergency planning zones have been established. These are reasonably sized geographic areas that require detailed preparations. In the case of Darlington, there is a contiguous zone at 3 kilometers from the plant, the primary zone at 10 kilometers from the plant, and the secondary zone at 50 kilometers from the plant. Each zone is associated with pre-planned actions which may need to be carried out in the event of an emergency. As is mentioned briefly, an important aspect of emergency planning and response is the establishment of protective action levels, or PALs for short. PALs are levels or ranges of doses intended to assist emergency response authorities on choosing appropriate protective actions to protect public health. For example, whether or not to evacuate. We will speak more fully to the concepts of protective actions and protective action levels in the next 2 slides. Protective actions consist of key actions that the public may be called upon to take in order to minimize their exposure level or dose. These include sheltering, meaning that people are instructed to stay inside and take other measures such as closing windows. Evacuating, where people are instructed to leave an area and relocate to a safe area, whether it be an emergency reception center or elsewhere. Another protective action is the ingestion of potassium iodide pills, or KI pills for short, either before or shortly after exposure to prevent or reduce the intake of radioactive iodines. Once in the bloodstream, iodine is taken up by the thyroid gland. By saturating this organ with stable KI, absorption of radioactive iodines is inhibited. Note the list is not exhaustive. There are other protective actions that may be taken. However, these are the examples most applicable and the focus of this study. This slide shows protection action levels based on a dose or dose range that have been established for Ontario Provincial Nuclear Emergency Response. The PNERP is intended to be flexible, and it is for this reason that the evacuation and sheltering protection action levels are reported as a range. For example, for evacuation, it ranges from 10 millisieverts to 100 millisieverts whole body doses. What does this mean from a nuclear emergency response? Practically, in the event of an incident, initial modeling and or measurements will help predict doses at certain distances, and those dose predictions are compared to the protection action values to help determine what protection action may be needed. In addition, there's a thyroid blocking protective action level, also known as potassium iodide pill ingestion of 50 millisieverts to the thyroid, which is in alignment with the International Atomic Energy Agency's and other guidance. The Ministry of Health and Long-Term Care has responsibility when it comes to deciding on the administration of potassium iodide in Ontario. As stated on the previous slide, protective action levels could be applied for a given dose or a range of doses. For the purposes of determining the application of protective actions in this study, center-line doses were used. That means a straight-line dispersion was assumed that does not account for many meteorological conditions that are likely to more widely distribute the radiological contaminants. The lower protective action levels for sheltering and evacuation were chosen and applied for this study in order to determine how far to evacuate, then subsequently how far to shelter. For those individuals evacuated, the model assumed that they received 0 dose. For those distances where sheltering was applied, a dose reduction of 20% was credited to the dose values. This is a conservative reduction, as sheltering can provide up to 40% reduction in dose. 20% was chosen to reflect the model used, where emphasis is on those pathways into the body of most relevance, in this case, inhalation during the first 7 days after the release. For thyroid blocking, for those who took potassium iodide, it is assumed that the potassium iodide pills are available to residents in advance of the radiological exposure, and that ingestion is done in the time frame prior to or immediately after exposure, resulting in a 100% dose reduction, i.e. 0 thyroid dose. In order to determine the appropriate type of dose input to the human health risk assessment, a population-weighted approach consistent with what has been done in previous environmental assessments for nuclear power plants was used. The model considers and calculates the impact of the variation of dose away from the plume center line, known as off-center line doses, when computing this population dose. The result is used to calculate the population dose in each of the ring sectors we had on the previous slides, to obtain many values of population dose for each sample case. The average dose in a ring corresponds to the calculated average population dose over all the sample results divided by the population in that ring. Therefore, the average dose represents the average individual's dose in the ring being evaluated. It is of note that the average dose does underestimate the risk to the most exposed individual. For that reason, a maximum dose at the 95th percentile was also used in risk predictions. The value is indicative of the risk to a very small fraction of the population that could be affected by the accident. In terms of human health, the focus of the study was to examine the possible impact on cancer incidence. Cancer is what is described as a stochastic or latent effect, where the probability of occurrence is proportional to exposure or dose. Tissue reactions, where there is a threshold below which effects are not observed, such as acute radiation sickness, were not quantitatively assessed in the study, as the estimated doses were all below the threshold doses for development of these tissue effects. The methodology used for the human health risk assessment is consistent with international practice. Increased cancer risk for several types of cancer were quantitatively assessed using a radiation risk assessment tool, or RAD-RAT for short. RAD-RAT is based on scientifically sound methodology. The risk models used by the risk calculator are broadly based on those developed by the biological effects of ionizing radiation, known as the BEER-7 Committee, for estimating lifetime risk for radiation-related cancer. This slide is a screenshot of the RAD-RAT tool, which is available online for anyone to use. It was developed by the National Cancer Institute and is meant for individuals with life expectancy and cancer rates similar to the general population of the United States. The lifetime risk estimates are based on the cancer incidence rates for the 2000-2005 population in the United States combined with survival data. It was used in the study because both the Canadian population and that of Ontario have similar cancer rates to that of the United States population for all solid cancers combined, thyroid cancer, and leukemia across multiple age categories. The screenshots shown on this slide indicate some of the inputs and outputs of the tool for illustrative purposes. Some of the inputs required include gender, birth year, exposure year, the organ that was exposed, and whether the exposure was acute or chronic. The primary risk quantity described in this document and shown on the slide is the excess future risk, which is the risk that can be attributed to the radiation exposure, in this case from the accident, from 2014, or in this case the time of exposure, until the end of expected lifetime. To put this in context, the baseline future risk, which is the risk that would exist in the absence of the radiation exposure from the accident, is also provided. For the human health risk assessment, several cancers were considered. For all cancers combined, leukemia and adult thyroid cancer, a 30-year-old male was used as a representative of the adult population. For childhood thyroid cancer, a 4-year-old female was used as a representative of the child population. Note that the 4-year-old female was chosen simply to represent a young child, in the range of 0 to 5 years that is considered a young child by the International Commission on Radiological Protection, or ICRP for short. Also in accordance with ICRP guidance was that a dose conversion factor was used for a 1-year-old. The age of 4 was selected as representative. Choosing a slightly different age of exposure had very minimal impact on the risk assessment results. With regards to the choice of cancers examined, all cancers combined provides an overall risk value to give a general idea of increased cancer risk. This category refers to the sum of many cancers. This category includes a number of cancers with varying degrees of radiosensitivity. For the purposes of this health risk assessment, an organ dose, also known as an equivalent dose, is required for the analysis. The colon was chosen to represent the dose to all organs because it can illustrate effects in dose to deeper tissues that experience shielding from the more superficial tissues of the body. It is relatively centered in the body from a physiological perspective. It is a highly radiosensitive organ, and it is not gender specific. Leukemia and thyroid cancer were both analyzed specifically and separately, as they are known to be highly radiosensitive cancers. In the case of the analysis carried out for thyroid cancer, the child receptor was examined in addition to the adult receptor. It is known, based on the experience from the Chernobyl and Fukushima accidents, that childhood thyroid cancer is a very sensitive indicator of adverse health effects after an accident. Adult thyroid doses were multiplied by a factor of 3 to obtain child thyroid doses. The factor of 3 reflects the ratio of a child's thyroid dose to that of an adult by taking into account the respective inhalation dose conversion factors and the breathing rates. I will now pass the presentation over to Melanie Rickard to speak to the results of the study.
Good afternoon. My name is Melanie Rickard. For the record, I'm the Acting Director of the Radiation and Health Sciences Division. A concern raised during the Darlington refurbishment environmental assessment hearings was the adequacy of the emergency planning zones for evacuation purposes. For some scenarios examined, evacuations of only up to 3 kilometers were needed, as shown on the slide. For the worst-case scenario, from a protective action perspective, which was the 24-1 scenario, using the lowest evacuation criteria based on an estimated 10 millisievert whole-body dose, the primary planning zone would be protective. Note that in this study, while the primary zone is a distance of 10 kilometers from the site, 12 kilometers was the closest distance evaluated in the model. The PNERP and its execution are inherently flexible. Depending on the circumstances, the province could, for example, use a PAL that is above the lowest value of 10 millisieverts in the range, evacuate beyond the primary zone, or implement other protective measures such as sheltering. For all remaining scenarios and the sensitivity cases where the source term was increased 4-fold, evacuations were all required at distances less than 12 kilometers. With respect to the human health results, it would be nearly impossible to distinguish most radiation-induced cancers from baseline cancers examined in this study. Of note, childhood thyroid cancer is the only radiation-induced cancer that could be distinguished from baseline cancers. Increased risk for childhood thyroid cancer was predicted for all scenarios. For example, in the 24-24 times 4 scenario, where the source term was increased by 4-fold, the predicted excess future risks of developing childhood thyroid cancer was an additional 0.3% above the baseline future risk of approximately 1% in close proximity to the plant. We will look at these results in more detail in coming slides. However, before doing so, it is necessary to reiterate why a hypothetical nuclear accident was modeled. The point of the study was to examine the human health impacts in terms of cancer risk from a hypothetical accident. A source term was selected and assumed to be released into the environment. As such, many design elements, safety system features, and operator actions were not considered in the study. In reality, all of these elements are in place to prevent and mitigate such an event. The first graphic shown here is demonstrating the excess future risk of developing all cancers combined for the early release scenario, also referred to as a 24-1 scenario. Some of the assumptions made in this study are described in the text on the left side of the slide. Individuals are assumed to remain in a fixed location for 7 days, had they not been evacuated, the time frame of the study. The protective actions assumed to be taken for this particular scenario were evacuation to a distance at 12 kilometers from the plant, sheltering between 12 kilometers and 50 kilometers, and no credit was taken for potassium iodide pill ingestion. To fully understand what this graphic is telling us, I draw your attention to the legend, which is displayed in the upper right corner of the slide. The gray portion of the cube represents a total of 100,000 chances. The blue portion of the cube represents the baseline future risk of developing cancer that may not be attributed to exposure to radiation from the accident. The gold portion of the cube represents the excess future risk of developing cancer that can be attributed to exposure from the accident. The results of the risk calculations will now be described. At 20 kilometers, exposure from the accident would result in an additional 0.42 chances on top of the existing 49,114 chances out of 100,000 of developing all cancers combined. At 36 kilometers, this number decreases to an additional 0.13 chances out of 100,000. And finally, at 50 kilometers, this number decreases further to an additional 0.07 chances out of 100,000. The next graphic is showing the excess future risk of developing all cancers combined, but this time for the 24-24 times 4 scenario. This scenario has the greatest impact on doses and the resulting risk. Again, assumptions made in this scenario are described in the text on the left of the slide. The protective actions assumed to be taken for this particular scenario were evacuation to 3 kilometers from the plant, and sheltering between 3 kilometers and 20 kilometers. Note here that there is an error on the slide. Ki pill ingestion was assumed to be taken at distances between 3 and 6 kilometers, not between 3 and 26 kilometers. With a source term that has been increased fourfold, as you can see, the gold section of the cube, is now more visible. At 6 kilometers, exposure from the accident would result in an additional 4.9 chances on top of the existing 49,114 chances out of 100,000 of developing all cancers combined. At 12 kilometers, this number decreases to an additional 2.3 chances out of 100,000. And at 20 kilometers, this number decreases further to 1.4 chances out of 100,000. This graphic presents the excess future risk of developing childhood thyroid cancer for the short-release scenario, also referred to as 24-1. The protective actions assumed to be taken for this scenario were evacuation to 12 kilometers from the plant, sheltering between 12 kilometers and 50 kilometers, and no credit for Ki pill ingestion. At 20 kilometers, exposure from the accident would result in an additional 41 chances on top of the existing 1,078 chances out of 100,000 of developing childhood thyroid cancer. At 36 kilometers, this number decreases to an additional 11 chances out of 100,000. And at 50 kilometers, this number decreases further to an additional 6 chances out of 100,000. Thyroid cancer is a rare disease and is thus associated with a small baseline future risk. Thus, the blue box in this graphic is notably smaller than those in the others presented thus far. The greater excess future risk is also notably larger in this graphic, as indicated by the gold box. This final graphic is showing the excess future risk of developing childhood thyroid cancer, but this time for the 24-24 times 4 scenario. This scenario has the greatest impact on doses and resulting risk. The protective actions assumed to be taken for this scenario were as follows: evacuation to 3 kilometers from the plant, sheltering between 3 kilometers and 20 kilometers, and Ki pill ingestion was assumed between 3 and 6 kilometers. At 6 kilometers, exposure from the accident would result in no additional chances of developing childhood thyroid cancer because KI pill distribution was warranted, because KI ingestion was warranted according to the thyroid blocking PAL and was assumed to be 100% effective. At 12 kilometers, an additional 301 chances of developing childhood thyroid cancer on top of the existing 1,078 chances in 100,000 was found. At 20 kilometers, this number decreases to 178 chances out of 100,000. The largest increase in excess future risk in this study is demonstrated here at a distance of approximately 12 kilometers from the plant. It has been well established that the child's thyroid gland is a radiosensitive organ. The results from this study are broadly in line with the radiological impacts that were observed following the Chernobyl accident. It must be noted that thyroid cancer is a treatable disease and has a 98% survival rate in Canada. The increased risk found in this study is likely overestimated as it is based on model dispersion in doses rather than direct measurements. Inherent in this modeling are many conservative assumptions. The Fukushima experience has indicated that detailed dose assessments based on environmental measurements and personal dosimetry were, on average, 2 to 5 times less than model doses from earlier predictions. Further, the United Nations Scientific Committee on the Effects of Atomic Radiation, or UNSCEAR for short, has stated that an increased incidence in cancer is unlikely to be observed in the future in Japan. In addition to assessing the risk of developing cancer, psychosocial effects arising from the accident were also considered. An expert from Pacific Northwest National Laboratories in the United States, Ms. Christy Branch, who is with us via teleconference today, was requested to carry out this assessment on behalf of CNSC staff. Key psychosocial effects would be anticipated for all scenarios and could include fear of radiation exposure, anxiety, and stress. The severity and duration of these effects would likely be related to the length of time the protective actions were in place, the amount of radiation released from the plant, the information provided to residents by the plant operator, emergency response organizations, and regulatory authorities, as well as the length of time individuals were prevented from returning to their homes, communities, and daily activities. In general, these effects decline relatively rapidly over time for most of the affected population once they are able to return to their normal life patterns. Clear, credible, and regular communication from responsible parties before, during, and after the emergency would help to minimize these effects. Non-human biota was also looked at in a qualitative way, whereby the results from the Darlington New Nuclear Power Plant environmental assessment were used as a basis for drawing some conclusions on non-human biota. This was possible because similar scenarios were looked at, namely the 2472 scenario in both studies. As such comparisons were able to be done, where no acute effects were expected when comparing estimated doses to non-human biota with that of internationally recommended thresholds. The theoretical increased risk in childhood thyroid cancer may suggest that further consideration is needed in how sensitive receptors are considered in certain aspects of emergency planning and response. For example, the study suggests the importance of potassium iodide pills being readily available for those who may need it. It is important to stress, however, that all emergency plans are based on the premise of protecting the most sensitive in the population. Further, these plans are flexible and are designed to address the unique aspects of any given emergency situation. From a risk acceptability perspective, you may recall earlier in the presentation when we referred to an incremental lifetime cancer risk for chemical and radiological carcinogens of 1 in 100,000 is deemed to be essentially negligible. In the current study, the very low probability of the hypothetical accident that is the basis for the dose and risk assessments is an important consideration, as is the fact that the post-Fukushima safety enhancements, including the availability of emergency mitigating equipment, would further reduce the probability of occurrence of a severe accident by a factor of approximately 10, and also mitigate the release. The ability of provincial nuclear emergency response planning to effectively reduce the health risk, combined with the very low likelihood associated with a severe nuclear accident as a result of Fukushima enhancements, for example, allows these risks to be effectively managed. Finally, the study insights around consideration of sensitive... Am I done? Okay. Excuse me. Finally, the study insights around consideration of sensitive receptors. Pardon me. Finally, as requested by the Commission in the Pickering Hold Point hearing, CNSC staff has examined whether a similar study is needed for Pickering. Given the results of this study and the similarity of the Darlington and Pickering sites, we would not anticipate different findings for the following reasons. First, geographically speaking, the two stations are in similar locations, being 35 kilometers apart on the shores of Lake Ontario. The locations also experience similar meteorological conditions. Secondly, the generic large release is based on CNSC's large release safety goal. Therefore, the source term that would be considered for an analogous study at Pickering would be the same. Thirdly, the same source term experiencing similar dispersion would result in very similar individual dose results. Fourthly, the population distributions are very comparable. Pickering, however, does have a larger population in close proximity to the plant. Thus, while the individual risk would not change, the number of individuals experiencing that risk would be greater. Finally, the study insights around consideration of sensitive receptors would apply to any nuclear power plant in Canada, not just Darlington. We will now conclude the presentation with a brief overview of the path forward. The draft study document, which has been discussed here today, was released for public consultation on June 4th. The consultation period will close at the end of August. Based on the feedback received from the Commission and other stakeholders, the draft will be finalized and published. This concludes our presentation. CNSC staff, OPG, and other experts are prepared to respond to your questions. Thank you for your attention.
Thank you.